So I would say the performance status of the patient is probably the most important factor. You see these patients go through their initial high-dose methotrexate, so you see how they tolerate their initial chemotherapy also. So performance status, I would again say, is probably the most important thing, followed by adequate renal function, adequate cardiac function, and pulmonary function.
Do you use any age cutoff at all?
We've typically sort of shunned against doing transplants in patients older than 80 or so. But having said that, I would say just how the patient looks and his performance status is probably more important than his physiological age.
I just seen yesterday somebody 5 years out from transplant. We know we cured a significant proportion of those patients who can go for consolidation. We kind of gave each other a hug. And then the question from the patient was, so do you still want to see me, or what happens next? How long do you see your patients after transplant consolidation, or when do we think this disease is cured?
So usually, if the disease doesn't recur in the first 5 years, I would say the chances of the disease coming back is very, very less. So usually at the 5-year mark, when I'm discussing with my patient, we kind of give an option of, do you want to follow us once a year annually versus do you want to see your primary care doctor? And usually a majority of patients prefer follow-up with oncology at least once a year, more for like reassurance.
Okay. So the follow-up maybe once per year, kind of, or even longer than 5 years.
Yeah.
But up to 5 years, what do you do? So what's the frequency of the imaging studies, and how often do you see those patients after, let's say, transplant consolidation?
So usually for the first 2 years, I'm seeing them every 3 months with an MRI. After the 2-year mark, from the 2 to 5-year mark, then we're seeing them every 6 months with an MRI of the brain. And then after 5 years, it's usually annually.
Yeah, I really like what you said, because I actually kind of tend to do something very similar to what you do. And, in curable lymphomas, there were some papers and some discussion that you don't necessarily need to follow patients with the imaging studies because they're most likely cured and so forth. And if they recur, you can still salvage them. But with CNS lymphoma, it's very different. If they recur, they sometimes present with symptomatic disease, which can be quite devastating. So I think this, at least in my practice, I tend to do those imaging studies periodically, and I adjust the frequency to the duration of follow-up, just exactly as you're doing. I see Christian's agreeing with it as well, and Kathy doesn't protest.
I agree completely with her plan. We like to see our patients, and we also want to see those success stories. And I think that making sure that we can do even regular scans, even if the interval is spread out, I think it does lend itself to reducing scan-xiety in our patients, which it can be real. But it's important to continue to watch them. I agree with you, Greg, that primary CNS lymphoma is a special, different entity where you can get those late recurrences.
There's something about this. Well, first, there's an IPCG guideline about how to image, and this is exactly what we heard. But there's throughout the literature, there are people that have recurrences 5, 10, 15 years later. That's why we do these things. But that was before the transplant era. And so our transplant study was like 20 years ago when we started it. So these patients are now 15, 18 years out. And we have seen that after the 2-year mark, which is usually when recurrences happen, none of those patients recurred. So I think that down the road, with more and more patients going through transplant and being literally cured, that there might be an adjustment in the guidelines to say, okay, if the patient prefers to have an image, then you image, but after 5 years, most likely it will not recur. But again, the data is not really that matured yet to have hundreds and hundreds of patients being 10 years out from their transplant.
Kathy, are there long-term survivorship issues for those patients, which you would mention?
I think that the long-term survivorship was really around the methotrexate and leukoencephalopathy, if they did have damage to their brain, if that did occur. Did they have radiation? This is something that they can have long-term consequences, whether they had a higher dose of radiation and then become to have more cognitive effects, develop a more of a late delayed encephalopathy secondary to radiation. And then patients can also develop, because we radiate their whole brain, they can also develop a picture that looks like normal pressure hydrocephalus, that can lead to gait dysfunction and cognitive dysfunction and problems with urinary incontinence. So again, like to follow those patients later on. If they do get radiation, remember, if you radiated the whole brain, you also radiated the blood vessels. So there is a risk of vascular complications that can occur. And then I already mentioned radiation necrosis, which is very particular.
No, thank you. Those are very valid points. Unfortunately, you're using less and less radiation, as you pointed out at the beginning. And I must say that the patient which I just seen for a 5-year follow-up is working as an accountant and extremely sharp. So that's good to see that, although those complications do happen, a majority of patients actually do very, very well, provided they can achieve this remission and consolidation after transplant, which is really something which in my clinic brings me a lot of pleasure to see how people recovered from being incapacitated, sometimes with profound mental status changes or neurological deficits, and then see reversal of those over time, and be able to see them going back to work or to function is really very rewarding, and I think we all have seen it. So. Christian, can you comment on some of this data which basically made radiation therapy mostly obsolete as a consolidative approach, and why we worry so much about radiation?
Yeah, so first, why do we worry? Radiation to the brain is not benign. There's a lot of things that can happen to the brain, particular leukoencephalopathy or white matter changes. So people also develop atrophy, and associated with that, they have neurocognitive deficits, memory issues, even personality changes. And so it's not a great thing to use in the brain. Also, it's a whole brain radiation, so it's not like what we do in gliomas, where we focally radiate and, for example, the temporal lobes spared and things like that. But in primary CNS lymphomas, it's just whole brain radiation. And there was a phase 3 study in Germany that used methotrexate followed by whole brain radiation or not, and there was a progression-free survival benefit with radiation, but no overall survival benefit. Now, that was a phase 3 study, and it's good and negative aspects. We all, I think, agree that single-agent methotrexate is not the most strongest agent, and they recognized that throughout the trial too, and added on a phosphamide. So, but at that time, everyone kind of shied away from radiation. We also got more aggressive with chemotherapy, with stem cell transplant, rituximab was introduced. And so, everyone kind of, again, shied away from radiation. Now, recently, or not recently, but the data was presented recently, but the NRG asked that question again, but slightly different, by using RMVP chemotherapy, the one that we use, followed by cytarabine consolidation with or without low-dose whole brain radiation. So the idea was to bring the radiation from 30 gray to 23.4 gray, by that time reducing the effects on cognition and white matter changes. And that, so far, has shown a 2-year progression-free survival of 80% versus 60%. And so we still don't know if that pays out in the long term with overall survival. So we're waiting for that. But with that data, there's a little bit of a resurgence of radiation. I personally like radiation because it is effective. And lately, I'm, especially with patients in secondary CNS lymphomas and transition or bridging them from a very aggressive recurrence in the brain to potentially a CAR T-cell treatment, I think focal radiation is a very, very powerful tool.
Yeah, absolutely. Focal radiation, particularly in a salvage therapy as well, can be a very powerful tool, and a number of patients really benefit from it greatly. Sometimes I think, trying to use different medical treatments, maybe we just delay it even for too long. But it is definitely a very active treatment overcoming some of the chemo resistance issues which you mentioned.
On the comment of radiation, I I feel like I'm gonna again agree with Christian. I think that radiation can have a place. I never tell my patients that it's completely off the table. I say there may be someday that you need it, and you really need to focus on that multidisciplinary team. When you want to take your patient to tumor board, if there is a recurrence, and to evaluate for possible clinical trials in that space.